Respiratory 202, Chapter 26. Pediatric airway disorders and parenchymal lung diseases. The upper airway includes the epiglottis, which is long, floppy and angled away from tracheal axis. The larynx, which is higher in neck in kids and is hidden by the tongue. And the cricoid, which is the only complete ring and is the narrowest airway section. Airway obstructions are seen with an X-ray showing AP and lateral views of the head and neck. Stridor pitch. If low, this is a mild obstruction. If high, this is more distress. If only on inspiration, this is a ball valve obstruction and is a risk for a pneumothorax. If there is no air, this is an emergency. Upper airway disorders that are supralaryngeal include choanal Pierre Robin, which is a small jaw, and oropharynx that can cause a tongue occlusion. Treatment would be to insert an airway, place them prone, and then surgery. Deep neck infections. Tonsil enlargement, which is treated with an antibiotic unless it is severe. A paratonsil abscess, which forms unilaterally around the tonsil tissue and causes a uvula deviation. The affected tonsil protrudes to the airway and causes trismus, torticollis and a hoarse voice. A retropharynx abscess occurs in children younger than 3. Posterior pharyngeal wall is displaced forward. This causes dysphagia, voice change and foul breath. Treatment includes a lateral X-ray, drainage and surgery. Upper airway disorders that are periglottic include epiglottitis, which is a life-threatening bacterial infection on the larynx. Causes include H. influenza type B, which is the most common, AB hemostrep, thermal or trauma. Signs include a high fever, severe sore throat, dysphagia with drool, cough, stridor, air huger, cyanosis and severe respiratory distress. Diagnosed with a lateral X-ray that shows the thumb shape. Treatment is an artificial airway for 12 to 48 hours, antibiotics and a bronchoscopy before extubation. Upper airway disorders. Periglottic continued. LTB, also known as croup, occurs with the presence of mucosal edema and exudate from the larynx to the bronchus. It is the most common obstruction in 6-month to 6-year-olds. It is especially common in the winter. Causes include parainfluenza 1, which is the most common, RSV, HSV and mycopneumonia. Signs include a low fever, malaise, rhinorrhea, hoarse, stridor and respiratory distress. Diagnosis is done with a lateral X-ray that shows the steeple shape. Treatment includes humidity, racemic epinephrine, steroids and intubation. The lower airway. The trachea divides to the mainstem then to smaller generations. Adults have 23 generations. Infants have 16 to 17 generations. Less generations means swelling can cause distress easier. RSV is the most common cause of the swelling. Lower airway disorders include bacterial tracheitis, which is a complete obstruction and resembles LTB. Tracheomalacia, which is a collapse caused by abnormal rings. Causes include high pressure in neonate vent patients, chronic trauma and external compressive structures. Signs include a chronic wheeze and possibly cyanosis and bradycardia if agitated. Treatment is time to grow and if severe, a tracheostomy or ventilation. Lower airway disorders continued. Congenital tracheal or bronchial stenosis occurs with TGA. A vascular ring is formed from the aorta wrapping the esophagus and trachea. It is caused by complied rings. Signs include difficult feeding and a chronic wheeze. It is a rare disorder and has new surgical techniques. Intraluminal obstructions include endobronchial tumors and cardiomegaly. The only treatment is surgery. Lower airway disorders continued. Foreign body aspiration is the lead cause of accident death and the treatment is removal with a bronchoscopy. Acute bronchitis is a viral small airway infection and it is associated with RSV. It is the top cause of hospitalization and is common in infants younger than 1. Causes include premature birth, chronic disease, CHD, crowded environment, daycare and smoke. Signs include a cough, respiratory distress, wheeze, rhonchia and apnea. Diagnosing is done with a nasopharyngeal aspirate or lavi sample. Treatment includes support, monitor, suction, O2 and intubation.